Good afternoon. My name is Emily Blumberg, and I'm the president of the American Society of Transplantation. I'd like to welcome all of you to our first ever multi-society international webinar on COVID-19, organ donation and transplant town hall. The webinar that you're about to partake in is one that represents the very hard work of a large number of people, both organizers and presenters, who have been dedicated to trying to bring you the most up-to-date information on COVID-19 and its impact on transplantation. We all know that everyone on this call wants to do the best for all of our patients, trying to help them in real time with the latest innovations. And so what we've tried to do today is present information from around the world that we think will be useful to all of you. We know that this is being aimed at only specific societies, but in our interest to be totally transparent and to communicate fully with societies throughout the world, we will be making this available both to other members of your societies through your society web pages, as well as to any other societies that have interest in listening to this webinar after the fact. So please be able to assure your colleagues that this information will be available to everybody when it is completed today. With that in mind, and given the large amount of information we would like to convey to you in the next 2 hours, I'm going to turn this over to our first moderator. But before I do so, I'd like to show you the societies that have been involved in this. And here you can see, I'd like to give a special thanks to members of AOPO, AST, ASTS, ESOT, ISHLT, NATCO, UNOS, and the Transplantation Society for all of their hard work on this. And if you go flip to the next slide, you'll be able to see all of our presenters, and I mean our planning committee, who have worked so hard on this particular webinar. So, and I apologize, I left out CST, my screen was partly blocked. So with that, I'm going to turn this over to Dipali Kumar, who will be presenting to you the first set of speakers. Also, in addition, there will be information in the handout area with today's agenda and list of speakers. We're also trying to keep you updated with resources that have been supplied by the organizers that may be of help to you and your institution, and that's all available in the handout area. Thank you. Dipali?
Thanks, Emily. Welcome, everyone. My name is Dipali Kumar. I'm a transplant infectious disease specialist at the University Health Network in Toronto. And what we've done is divided the webinar into 3 or 4 sections. The first section will deal with presentation, treatment, and prevention of COVID-19. And I will introduce all the speakers. We have a number of speakers that will be going through this. Dr. Erica Lees is a transplant pulmonologist at the University of Washington. She will be followed by Dr. Ajit Lemay, who is a transplant infectious disease specialist at the University of Washington as well. We'll then have Attilio Iacovoni of the Heart Transplantation Unit in Bergamo, Italy, followed by Paolo Grossi, Transplant ID at the University of Insubria in Italy. And finally, we'll have Marion Michaels, who is a pediatric transplant infectious disease at the Children's Hospital of Pittsburgh, who will be discussing prevention, and then Lara Danziger-Isikoff, who is pediatric transplant ID at Cincinnati Children's Hospital. After everyone has done their presentations, we'll be doing a Q&A. And depending on the amount of time we have. So I will ask Dr. Lees to go ahead.
Great, thank you. And thank you for having me here to talk with you all today. You can move forward the slide. As was mentioned, I'm at the University of Washington in Seattle. Next slide, please. So I'll be talking about the background and presentation of this viral pneumonia illness. And so, as I'm sure most everybody knows, that there was a cluster of pneumonia cases that occurred in Wuhan, China in early December 2019. And it was ultimately identified and termed as a novel coronavirus infection, or 2019 nCoV. After more research was done, it was found to be an enveloped RNA beta coronavirus that was phylogenetically similar to SARS-CoV, which is a severe acute respiratory syndrome coronavirus, and so it was thus renamed as SARS-CoV-2. To be clear, COVID-19, which stands for Coronavirus Disease 2019, is the disease that is caused by the virus SARS-CoV-2. The infection spread quickly, and on March 11th, 2020, it was designated as a pandemic by the WHO. You can see here I included a map of the world that really there's no area that has not been touched by this virus. And the numbers below I added actually on Friday, and I have updated numbers. This also comes from the WHO. Now, since Friday, there are now 332,000 confirmed cases of coronavirus, of COVID-19, more than 14,000 confirmed deaths, and 190 countries, areas, or territories that are currently affected. Next slide, please. So we have a couple of reports that are telling us about the presentation of COVID-19. The initial report came out of the Wuhan, China group and was published in JAMA. And they reported the most common symptoms being fever in 99%. You can see the cutout from their presentation or for them paper right there, and dry cough in almost 2/3. About a third of patients had dyspnea. I do want to point out that those patients, the reports on these patients were from hospitalized patients, as is the second one that I'll review. So we don't have as much information about patients who may have more mild disease and what are their most common presenting symptoms. So the second report was published in New England Journal, and it was a larger report from China. Most of the patients were still the patients coming from Wuhan, but it also included other patients in China. They reported fever at presentation of 44%, but again, this was focused on patients who were hospitalized, nearly 90% of the patients ultimately developed fever during their hospitalization. They saw a cough that was somewhat similar, about 68%, although they did see about a third of patients had a productive cough, and they saw dyspnea in about 20%. Comorbidities have definitely been reported as being higher likelihood of developing COVID-19. These two papers ranged anywhere from 23 to 46%. And using the paper in New England Journal and then another paper that was published in the Annals of Internal Medicine, it appears that the incubation period, again, by the data that we have, appears to be 4 to 5 days, but can be up to 14 days. And as we know, patients can be completely asymptomatic as well.
Ajit, we're ready for you.
Can you hear me?
We sure can. Go ahead.
Okay, great. Could we go to the next slide, please? All right. Thank you for the opportunity to participate. I think there's a lot of unknowns about how SARS-CoV-2 will intersect and impact with organ transplantation. I think there's a reasonable expectation based on analogy with other viruses in this setting that our organ transplant patients with their concomitant immunosuppression might be at increased risk potentially for acquiring the virus, specifically through either behavioral or biological features such as those that are listed here. And I think there's a lot of concern that there may be a higher likelihood of progressing from infection to more severe disease, perhaps as a result of underlying comorbid conditions as well as the impact of immune suppression. However, I will note that at least based on limited data with related coronaviruses, there wasn't necessarily an increased morbidity or mortality above and beyond that could be attributable to underlying comorbidities. And unfortunately, to date, the published data specifically on organ transplant patients with COVID is very, very limited. So I'm going to share with you in the next slide very preliminary data with our first 5 cases. Next slide, please. So I want to highlight a couple of important caveats as you look at these data, which literally could have been updated in the last few minutes since I've heard about a couple of additional cases. You'll notice that all of these cases are patients who are many years, more than 10 years, in some cases up to 20+ years after transplant, and as a result, were on low-dose maintenance immunosuppression. Number 2, when you look at these data, please keep in mind that at the University of Washington, with one of the first available on-site real-time testing laboratories, we were able to develop specific testing algorithms that called for testing all immunosuppressed patients with any signs or symptoms that could be compatible with COVID. And so that testing bias may also impact the cases that have been diagnosed to date. But as you can see, we've encountered organ transplants of all types, patients who had significant underlying comorbidities that have previously been described to be associated with an increased risk of morbidity and mortality. The symptoms that you'll see for these 5 cases are quite similar to those that have been described in a general population, not necessarily immunosuppressed. And one thing we've been surprised with is just the range of clinical presentations, from those mimicking a standard upper respiratory virus infection to one that was suggestive of viral pneumonia. And the actual clinical care that was undertaken for these patients was in the inpatient setting for 3 of the 5, but 2 of the 5 had relatively mild symptoms and were managed expectantly in the outpatient setting. The treatments that were undertaken in the majority of patients was simply supportive care without specific changes to immunosuppression, and only one of the 5 patients, the patient with most severe symptoms leading to acute kidney injury, was hydroxychloroquine administered along with a discontinuation of baseline MMF and the addition of prednisone. So far, with very, very short outcome, I want to emphasize all of our patients are alive at now approximately a week or greater into their clinical course. And so it raises at least the possibility that in patients who are very far out from transplant on low-dose immunosuppression, that perhaps the impact will be reflective of their underlying comorbidities rather than necessarily an attributable impact of immunosuppression. Next slide, please.
Okay, fantastic. First of all, thanks for your consideration. As you know, here in Bergamo, we had and we still have an explosion of COVID-19 patients. In addition, because we are a transplant hospital, we had also cases of COVID-19 transplant patients. And in total, we have observed 14 patients, but we present only the ones with the longer follow-up, 6 patients. Among them, we lost 2 patients. 2 patients are still in hospital, one stable, another unstable, and we have 2 outpatients. Next slide, please. Okay, let's start with the beauty. The first patient is a male, 15 years old, 4 months post-transplantations. He was on mycophenolate, cyclosporine, and 50 milligrams of steroids. He started to complain of fever, dry cough, but not dyspnea. And after 3 days, we decided to test him, and it was positive. At this time, the lab tests were normal. We just observed a slight increase of CPR, and the oxygen saturation was perfectly normal, with no respiratory distress. So our strategy in this case was to stop mycophenolate and follow him by phone. And now, after 14 days, I call him today. The patient is asymptomatic. The second patient is a very interesting one. He's a 4-year-old male, 4 months post-transplantation, was transplanted from an aggressive form of wild-type amyloidosis cardiomyopathy. He had renal failure after transplantation and other problems, but he recovered all his complications quite well. He's in cyclosporine and mTOR inhibitors. When we decided to discharge him to a dialysis out clinic, for this reason we tested him and it was positive. So at this time was completely asymptomatic. And our strategy in this case was just to wait and see. So I think the key message of this slide, we think that it's possible to have a very mild form of COVID-19, also in transplant patients, but we believe maybe that this is the exception that proves the rule. So next slide, please. Now let's speak about our inpatients experience. The first patient is a male, 66 years old, 3 months post-op. He was transplanted after 25 days of ECMO, so he had a lot of complications, but he recovered quite well. He was in cyclosporin and mTOR inhibitors. We tested him before discharging him to rehabilitations, and he was positive. So the day after the test, he started to have fever, cough, and the oxygen saturation was slightly reduced. So our strategies in this case was to stop everolimus, and we treated him according to our hospital protocol that at this time was an antiviral agent, Keltra, azithromycin, hydroxychloroquine. But to be honest, now we have stopped Keltra because it's a nightmare also with interaction with cyclosporin. We didn't notice any benefits. So the patient now is stable but still in oxygen max. The second patient is a female patient, 4 years post-transplantation. She was on cyclosporin mycophenolate. He started to have fever and dry cough, and after 5 days, he had developing worse symptoms. So for this reason, he was admitted to the hospital with respiratory distress. She was positive. Again, we tested him for COVID-19 infection. So in this case, our strategy was to stop mycophenolate. We start our hospital protocol, and she requires CPAP treatment, but now she's in really critical conditions. So the key message of these slides, I think, is that in COVID-19 is a very aggressive in immunosuppressive patients, and the patient could deteriorate very easy. So it could be reasonable to reduce as much as you can immunosuppressive treatment. So next slide, please. Okay. Finally, the last 2 patients, the one which we have lost. The first one is a male patient, 5 years post-transplantation, 6 years old. He was in azathioprine and cyclosporin. The first symptoms were fever and cough, but he came to the hospital late, after 7 days, in very critical conditions. The saturation was very low, and we lost him after 10 days. The second case that is quite interesting because it was a lovely lady of 74 years old, 29 years after transplantations. He was on cyclosporin, everolimus, and mycophenolate. He was admitted before COVID-19 outbreak in our hospital on 15th of January for a severe episode of heart failure due to antibody-mediated rejection. So we treated her with 4 cycles of plasmapheresis, rituximab, and she developed COVID-19 infection after the second dose of rituximab. And unfortunately, she died after 5 days. So I think the key message in this case is that if you have an outbreak of COVID-19 in your hospital, think twice before to treat any patient with high immunosuppressive regime. And thank you for your attention.
Yes, okay. Good afternoon to everybody, and thank you for the opportunity to share with you this couple of slides. So if I may have the next slide. So my task is to briefly speak about what are the treatment options that we currently have, and the first statement, and that there is no approved drug for the treatment of patients with COVID-19, either for the general population and particularly for the solid organ transplant population. And the clinical management includes infection prevention and control and supportive care, including supplementary oxygen, non-invasive ventilation, and mechanical ventilator support when indicated. So in my unit, I have 30 beds. They are all with COVID-19 patients. Hopefully, none of them are transplant recipients, but 50% of them are on CPAP or non-invasive ventilation because of severe interstitial pneumonia. And what we started doing was using, based on the Chinese experience, lopinavir, ritonavir, Calitra, but then the Calitra is not any longer available in Italy, so we switched to darunavir, ritonavir, or darunavir cobicistat as an alternative. And but there are no data to support this. This was just because we didn't have an alternative, and all these antiretroviral are used in combination with chloroquine that we don't have in Italy. We use hydroxychloroquine. And but recently, the data that have been published last Thursday on the New England Journal of Medicine from an underpowered trial have shown limited efficacy of lopinavir ritonavir, at least in the most severe patients. Apparently, there is some benefit if you start very early, but not very much when the disease is already there. And remdesivir is an investigational intravenous drug that inhibits the viral replication through premature termination of RNA transcription, and has in vitro activity against SARS-CoV-2, has been developed for Ebola, but then has been shown to be in vitro active against this new agent. And there are currently several ongoing randomized controlled trials that aim to examine the efficacy and safety of intravenous remdesivir for COVID-19, so 200 milligram and then 100 milligram per day IV. Next slide. And this is just a slide showing the figure of the improvement rate of patients treated with severe COVID-19 treated with lopinavir ritonavir compared to control. And as you can see, there is actually no difference. So the conclusion of this trial, that there's some intrinsic limitation, are that this approach is not so effective as we were hoping at the beginning of this terrible epidemics. Next slide. And there is accumulating evidence that suggests that a subgroup of patients with severe COVID-19 might have a cytokine storm syndrome, and tocilizumab is a recombinant humanized anti-human monoclonal antibody directed against the soluble and membrane-bound interleukin-6 receptor. And the drug has an intravenous and subcutaneous formulation. And from my preliminary experience in non-transplant recipients, because the drug, at least in Italy, but also in Spain, is not allowed to be used in patients with immunosuppression, including solid organ transplant recipients. I don't know if this will be different in the US or in other countries. But the preliminary results, so I treated yesterday 2 patients who were on non-invasive ventilation from a week with a very slow recovery or non-recovery, and today they went off the non-invasive ventilation, and they are just with some oxygen supplementation. So it's just anecdotal, but in some cases, with severe hyperinflammation, it seems to be really effective. The convalescent plasma that has been used in China is currently not recommended. There is the Survival and Sepsis Campaign guidelines that have been just published a couple of days ago, and this is a statement that I've taken from that guide, is that is not recommended in treating patients with COVID-19 until more evidence is available. And there are many vaccines under development, but none is currently available, and I think that it will take months before we will have something that we can use for preventing this infection in the general population and the solid organ transplant population. If I can go to my last slide, just to remind that particularly the PI, the protease inhibitor, the antiretrovirals, have major drug-drug interaction with many immunosuppressive agents. So the recommendation is to be very careful if you are going to use this drug in the solid organ transplant population, because you may run into overexposure of immunosuppression. Thank you very much for your attention.
If you go to if you go to the next slide and just hit enter 4 times, one more after that. Thank you. This was the problem of doing the slides at home. At any rate, I thank you for allowing me to talk a little bit about community and hospital preventive strategies, which I know many of us know already, but perhaps need to be emphasized again. Washing our hands, while it sounds simple, is really the mainstay of preventing transmission, and proper hand hygiene of 20 seconds with soap and water or alcohol sanitizer after touching any item that has been touched by other individuals before touching one's face, nose, or eyes is critical. It's important to avoid secretions of other people, and as the picture of the classic sneeze studies show, we really do need to maintain a distance of 2 meters or 6 feet. As a pediatrician, I always felt that teaching children hand hygiene and proper cough and sneeze etiquette was perhaps the most difficult, but as I have been observing my colleagues and my friends, I recognize that it is perhaps harder to educate older individuals who their entire life have been coughing and sneezing into their own hands. So I really feel like it needs to be emphasized again and again. To cough or sneeze into a tissue and throw it away, not put it in your pocket, or to cough into the crook of your arm if there is not one available. Self-quarantining is really important for our families and for our healthcare workers as soon as we get sick, rather than trying to simply power through, as we can be the transmitters to others, as perhaps shown on the slide that Dr. Ajit Lemay showed earlier, with 2 of their patients had acquired their infection while in the hospital institution. If there are symptoms, they should even try to be quarantined from their families, eating in their own bedrooms, using a separate bathroom if available, and cleaning and disinfecting the areas that have shared areas. Societal quarantining with staying at home as much as possible is quite important, particularly for our transplant patients, and decreasing the number of people with whom our transplant patients interact. And does it work? Well, the early data that came out of the Wuhan district of China suggests that it may or does. Dr. Zhongli Ren and colleagues showed a low incidence, much lower than what would have been anticipated, for their 87 heart transplant recipients in the descriptive survey that comes out today from the Journal of Heart-Lung Transplantation, showing that the majority of their patients did practice enhanced precautions of self-quarantining, and that this may have impacted the decrease in disease transmission to them. If we could go to the next slide. Preventive strategies within the hospital, and again, if you could hit it 4 more times. I think even once more or twice more. Fabulous, thank you. So sick patients, if you should be instructed to call the institution before they are coming in, so that we can know that they are coming pre-arrival, assess them and mask them quickly and isolate them. For proven patients or those that are persons of interest, negative pressure rooms, if available, and neutral rooms, if not available, are important. Again, limitation of people going into the rooms of proven cases or persons of interest. Personal protective equipment is critical, having mask, gown, gloves, and eye protection. And of course, we are finding all too frequently that we are running into shortages with this. in those institutions that have the capability, even having an observer to watch people putting on their personal protective equipment so that it is shown to be appropriately done is helpful. Saving the fitted respirator mask for aerosol generating procedures and not throwing them away, but having protocols and policies available for how to reuse for those individual patients. Cohorting patients is going to have to vary by institutional variability in your access to rooms, but trying to have them away from the transplant patients that are not infected is important and will be discussed in more detail by Dr. Humar later on. And again, hand washing frequently. The concept of should our patients be coming to appointments, I think has to be taken by case. One should think about whether or not this is just a screening appointment or one where there is a concern for them having rejection. Consider masking them when they get into the hospital, even if they are not sick, and having them ushered into a room to avoid touching areas that may have been touched by other people. Using teleconferencing will again be discussed later in this town hall, but is something that each institution should look into to not have patients come unnecessarily into the institution where they may come in contact with infection. And again, hand washing frequently, and I will stop there. Thank you very much.
Go to the next slide. Fortunately, we have some data from pediatrics, although it is quite limited. The majority of this data has come from China and initially indicated that less than 1% of the cases which were presenting to the hospitals were in children younger than 10 years of age. I think it's important to note that this information on this slide represents information in hospitalized children, both in Wuhan and the surrounding provinces, where the proportion of patients who were positive for SARS-CoV-2 ranged between 1.6 and 12.3%. The ages ranged from 1 day up to 15 years, and the majority of patients had fever. The patients who became critically ill, all at one institution at Wuhan's Children's Hospital, all had significant comorbidities. And to date in that population, there was only one death reported in a 10-month-old that had a comorbid condition with complicated intussusception. Neither of these institutions reported any transplant patients among those who were positive. Next slide. Since those initial reports, there's been a large report published last week in the journal Pediatrics of 2143 children who had COVID-19. 34.1% of them were laboratory confirmed, and the rest were presumed based on epidemiology. Again, the median age of these children was 7, and most interestingly, younger children and infants were more likely to have severe disease, with up to 10% of children under the age of 1 year having severe disease reported, and only 3% of those 16 and over with severe disease. Again, no transplant patients have been noted in this cohort either. I think it's also important to remember in this population that we're seeing increasing reports, both from China as well from other regions, that pediatric patients may be more likely to be co-infected with other respiratory viral infections, and that the presence of influenza, human metapneumovirus, RSV, or parainfluenza virus does not exclude necessarily a patient from being co-infected with SARS-CoV. Fortunately, to date, though, pediatric patients have fared much better than adult patients, although we need to be vigilant, and we are looking for people to actively report their patients should they become positive. Thank you.
Hi, it's Dipali. Can you hear me now?
We can, Dipali. Thank you.
Okay, perfect. Okay. So I just want to go back to when we were talking about the infected transplant recipients, and this is a question for Ajit. Ajit, do you have any general idea of whether the patients that we're seeing the transplant patients we're seeing have more severe disease than, let's say, non-transplant patients, from the patients that you described and that you've heard of?
Yeah, again, our experience, as I pointed out, is very, very limited, and I'm very interested to hear what our Italian colleagues are describing, which, again, is very different than our very initial experience with just 5 patients. Some of the limiting factors, I think, that may go into the picture that I presented with the 5 cases that were summarized are that they were all patients who were distant, means a median of 15 years after transplant on low-dose immunosuppression. And despite having significant comorbidities, so far, with very limited follow-up, the patients have generally done well. And it at least raises the possibility, based on what appears to be emerging from pathogenesis work, that perhaps the host response is as important as the virus in determining the course of disease. So could it be that despite having multiple risk factors for progressing or having very severe disease, that the very low-dose maintenance immunosuppression that these patients were on in some way might have modulated the expression of disease? Highly speculative at this point, but I was surprised, based on that, again, very limited experience, that none of the patients with 7 days of follow-up, to be clear, have progressed to requiring intubation or progressed to death, as has been described in many people with those same comorbidities who are not necessarily receiving immunosuppression. But that's a fundamentally important aspect of for all of us in transplant.
Mm-hmm. I guess the other issue is that I wonder if we are missing patients that have atypical symptoms that maybe are not even getting tested. I don't know if you've had any insight into that.
I think in part our experience has reflected the availability of rapid real-time testing as one of the first centers in the U.S. to have that go live. And we are finding a much broader range of illness, perhaps, than was initially recognized and described in China. And so one possible explanation for our findings of, quote, relatively mild disease is perhaps related to a testing bias, that our prospective testing recommendations and guidance that we've developed that are open for everyone to see through the UW COVID website are to test all immunosuppressed patients, solid organ transplant patients, who meet any of the criteria in terms of symptoms. So perhaps that has led to identification of patients who in other locales might never have been tested. So I think the indications for testing is probably going to turn out to be an important determinant of the expression or the recognized expression of COVID-19 in SOT.
Great, thanks, Ajit. Question for Paolo. Paolo, there's been a lot of talk on using hydroxychloroquine for treatment, for post-exposure prophylaxis, and for primary prophylaxis right after transplant. I'm wondering if you can comment on the side effects of hydroxychloroquine and what we need to do in terms of monitoring the patient for adverse effects.
So thank you for your question. So I don't think there is any evidence that chloroquine or hydroxychloroquine can be of any benefit as prophylaxis. So there is a lot of attention, and many people are using this approach, not just in transplant, but also in the general population. Many physicians in the emergency room are trying to use, but I just admitted a patient with a severe interstitial pneumonia due to SARS coronavirus 2, who was on chloroquine treatment from long time because of rheumatologic disease. So I'm not sure that is, I mean, it's just one case, so it's anecdotal, but I'm not sure that this is going to be of any benefit. And we are short of hydroxychloroquine, that is the only drug available in Italy, and we are using probably inappropriately. So I'm not sure that this is something that we should do. And in terms of side effects, so we should be careful for what is the potential QT prolongation related to chloroquine or hydroxychloroquine administration. So I'm not really convinced that this is the way to go to give everybody this drug. So there is a shortage of the drug, and in my personal experience, it didn't work at all as prophylactic agent to prevent severe coronavirus disease. So that's my personal point of view based on a limited experience, but I would like to see some strong data to support this before using universally in all recipients as prophylaxis.
Great, thanks, Paolo. I think, I'm glad you highlighted that, this hydroxychloroquine the supply may be limited, and also, we really don't have a lot of evidence of using it in infection or for prophylaxis. Just one last question for Attilio, if you're still on the line. You talked about immunosuppression withdrawal. Has there ever been any thought about actually giving steroid bolus to patients who have severe pneumonitis in terms of reducing the inflammatory response? It's sort of difficult to know what to do if we should try to reduce the inflammatory response versus withdraw immunosuppression to combat the virus. Just wanted to get your thoughts on that, Attilio.
Well, can you hear me?
Yes, we can,
Yes.
Attilio.
Okay. So our experience with steroids, we have tried in very advanced patients, and we didn't notice any substantial benefits. But in mild form and maybe in moderate form, we have used steroids to reduce the other dose of, for example, cyclosporin or tacrolimus, and we didn't notice any episode of rejections. So our standard protocol now is to use steroid in the mild form, at least, and reduce as much as you can the immunosuppressive therapy. But of course, we don't have any evidence. And on the other hand, when you treat advanced patients, I think it's always, you have a lot of bias, so it's difficult to understand if steroids is really appropriate.
Thank you. Okay, so in the interest of time, I think I just want to say thank you to all of you, and I think we can move on to the next section.
Great, thank you very much. For those of you who don't know me, I'm Lloyd Ratner. I'm a transplant surgeon at Columbia University in the city of New York, where we are now undergoing a huge surge of COVID-19 patients, and it's really pretty scary. I'm also the president of the American Society of Transplant Surgeons, and I'd like to just start by expressing my gratitude to Emily Blumberg and the AST staff and the AST community of practice for really doing the lion's share of the work of putting this together, and also for all the speakers and moderators who have participated in this. It's really been this has been put together in a relatively short period of time, so kudos to all those involved. This portion of the webinar, we're going to talk about getting to transplant, donor issues, and candidate concerns. And we have 5 speakers, and I'll introduce them now and then let them do their thing successively. Our first speaker is Mike Isom, who probably needs no introduction, but he's a transplant infectious disease doctor at Northwestern University in Chicago. Our second speaker will be Dr. Ajit Limay, who is also an infectious disease doctor at the University of Wisconsin. Our third speaker will be Kevin O'Connor, who's the president and CEO of the Life Center Northwest, which is the organ procurement organization that serves the northwest portion of the United States. Our fourth speaker will be Kelly Ranham, who's the CEO of the Louisiana Organ Procurement Organization, and she's also currently the AOPO president. And our fifth speaker will be Dr. Luciano Potina from the University of Bologna, who is associated with the cardiac transplant program there. So with that, let's move on to Mike Isom's presentation, please.
Great, thanks. And thanks for inviting me to present today. I do have some relevant disclosures. I'm a paid member of the Medical Advisory Board of ViraCore, which is doing coronavirus testing, including for some OPOs, and I'm the current chair of the NIH DMID adaptive trial for treatments for COVID-19. Next slide. So what I was asked to talk about today is a little bit about diagnostics and testing, and specifically, since it's in this organ donation realm, data for its use there. That second part is actually pretty easy because there's very limited data that I've seen in terms of its utility in that setting. So I'll just be able to present to you some information that we have from other data sets. As far as diagnostics are concerned, for the most part, we are always talking about PCR-based assays. For much of the world, there are some areas that have rapid antigen type kits, as well as antibody-based kits, which will be coming along very shortly and with FDA approval in the United States. For donor screening, though, PCR testing is the one that's most available. It's available at a number of different hospitals and commercial labs, and I left the FDA website where you can find the up-to-date list of testing sites. There are some limitations to testing at this point. There are variable availability of swabs, viral transport media, as well as availability of the actual assays, and in many cases, challenges with turnaround time. At our center, for example, those tests that are done in-house, which is currently just shy of 100 tests per day, we can get turnaround in about 6 hours, but for our ambulatory patients where it's sent to a reference lab, it's taking anywhere from 1 to 3 days to get the results back. The second question that oftentimes come up is, what is the false negative result? There's been a wide range of rates that have been reported in the literature, anywhere from around 2% to 22%. This is likely very much dependent on how the sample is collected. Does someone get a deep collection in the nasal pharynx? Is there good quality collection? Are patients early or late in the disease where utility of the PCR-based test because of relatively low viral loads may be less? The sample site, so whether you're talking about upper or lower tract diseases, we'll talk about in a second, as well as challenges potentially with lab assays or reagent errors. The other issue is where you're doing the test. We still have relatively limited data, but from what has been published from the study from China, the sensitivity of BAL fluid is 93%, nasal swabs 63%, and then nasopharyngeal swabs of 32%. So depending on where you get the testing, you may get lower yields if you're sampling the upper versus the lower respiratory tract. Again, these results are generally in patients that are relatively sick. I know we here at Northwestern have seen at least 2 patients with severe lower tract disease where the nasal swab was negative and the lower tract was positive. Next slide. The other thing which everyone is quite familiar with, this is a little outdated. The US number is up to about 250,000 tests that have been performed. But one of the biggest challenges currently is local testing availability. Many sites are doing some hybrid of local testing and send-out testing. Next slide. In terms of who to test, so this is taken in part, and I'll probably turn it over to Ajit, from what the guidance that they've provided about who to screen from the post-transplant side. Since we're talking about donor testing, I think really it depends on taking into consideration what your OPO has available to you and what the turnaround time has been. I know our OPO recently started doing testing. It is sent to a reference lab with results generally relatively quickly, although maybe longer than 12 hours. And so I think this is an area where we're going to need a lot more data for understanding the risk of false negatives in terms of how many patients test negative and end up having disease transmitted to recipients. And then what is the yield of this in screening for patients versus loss of organs because of false positives. That's all that I have. Thank you.
Okay. Well, thanks. I'm back. Despite rumors to the contrary, I am still at the University of Washington, that W, and not Wisconsin. All right, I've been asked to just cover donor management strategies, but really what I'm going to focus on in the next slide, please, is a framework for thinking about decisions, difficult decisions, about whether to continue organ transplantation at your center. And obviously this is a huge topic given the concerns that people have related to multiple aspects of transplantation, including some of the concerning clinical data shared by our Italian colleagues. And so this just provides some of the framework that we had in mind in thinking about our own transplant center's decision for at least now to continue with organ transplantation. And listed on the top two columns are arguments in favor of maintaining the ability to continue organ transplants, as well as on the other side, arguments against continuing transplantation. And the various domains that we thought through included some of the clinical aspects of transplantation, the impacts and ripple effect that go far beyond just the organ transplant population, particularly with constrained resources, with large numbers of patients in the community being admitted, financial considerations, legal considerations, and then finally, very importantly, ethical and moral obligations to patients who we list at our center for transplantation if we can do it safely. And at least for the present time, which is certainly subject to change as the situation changes, we have decided to continue performing organ transplantation except in our living donor programs. And again, this is a fluid, dynamic situation that may well change if, for example, we don't have enough PPE or other kinds of things. But one of the clinical factors that we thought about is, since much of the concern about what the impact that COVID would have, specifically in our organ transplant populations, we considered what would happen to our patients if they did not receive a life-saving transplant, including very high mortality rates for some of our sicker patients awaiting, for example, lung, liver, or heart transplants, and the fact that if we deferred transplantation, they would likely remain at risk through their multiple hospital and medical center contacts and potential risks of nosocomial infection. So I think each center should carefully consider whether or not to continue with transplantation, and this again provides just one conceptual framework for thinking about what might go into that decision. Next slide, please. One of the major concerns about transplantation, obviously a number of factors as shown in the previous slide, but is, can we transmit SARS-CoV-2 from the donor to the recipient? And I think really we don't have a definitive answer for that, and so this provides, at least through a critical literature review, what available data there are that either suggest the possibility of transmission on the left side, and the arguments against, or data suggesting that transmission may not occur, at least to certain non-lung, non-GI organs. think the data published from Wuhan and Chinese investigators have pretty clearly shown that both viable virus, culturable virus, is present in stool, and there is obviously, as the major target organ, the lung, a high level of concern about transmission in a unknowingly infected donor. However, our estimation based on the available data to date and drawing from analogies from what we know about other RNA respiratory viruses, including some close cousins of SARS-CoV-2, namely MERS and SARS from 2003, that the risk for transmission of active infection from a donor may vary significantly when one considers GI tract-related organs and lung organs versus non-lung organs. And I think that should be kept in consideration, particularly in the discussions about access to testing for donors that Dr. Eisen had just alluded to. All right, next slide, please.
Okay, great. Thank you. Can you hear me? Good. Thank you for this opportunity to review some of the donor strategies. And I'm not going to spend a lot of time on the testing. I think that's been well covered by Drs. Eisen and Dr. LeMay. I am going to spend some time talking about maybe 5 or 6 things that I think all of us working on the organ donation side can anticipate and should be prepared for. But before I do that, I'd like to just give an overview of the general approach that we're taking to the screening of potential organ donors. All of OPOs in the United States and elsewhere are striving to balance their ability to carry out their mission and maximize the number of organs available to the transplant community with efforts to mitigate the risk of disease transmission, obviously for patients, for the healthcare team, for OPO staff, and for recovery surgeons. So we're all in the same boat in that regard. Our routine screening now across the country includes the Uniform Donor Risk Assessment interview, which includes specific questions related to medical, behavioral, travel, social history that would be potentially suggestive of increased risk of exposure to the virus. We ask specific questions about whether or not there has been any history of signs or symptoms such as a fever, cough, shortness of breath, or evidence of lower respiratory tract disease, and of course, look at the epidemiologic risk factors related to recent travel in particular, and also ask specific questions now as part of this Uniform Donor Risk Assessment interview related to whether or not there's been a risk of exposure to a person under investigation for being infected with this virus. We also, in many parts of the country and some OPOs routinely now are doing chest CTs to determine whether or not there are CT findings that might be consistent with or are suggestive of exposure to the virus, in addition to the test results that we're obtaining. And of course, that's going to be to some extent a function of where in the disease progression we're doing the CT, and that's going to vary from case to case. As far as the testing goes, I think one of the current challenges we're faced with is that most of us, I believe, are leaning towards trying to do universal or routine testing on all potential organ donors. But there are challenges for many OPOs. They don't have access to a testing platform locally. And in some cases, they need to send specimens across quite a distance, which then can translate into several days of waiting time for the turnaround for the result to be available to them. So while we're not there yet in the United States, where every OPO is universally testing every potential organ donor, I think it's safe to say that we're rapidly moving in that direction. Some of us, like here in Seattle, are lucky enough to have the local testing facility. We're working closely with Dr. LeMay and his team, and I want to just acknowledge Dr. LeMay for his leadership and his willingness to partner closely with the OPO in this instance, so that both the University of Washington Medical Center Transplant Program and Life Center Northwest as the local OPO are working hand in glove to make sure that we're maximizing every opportunity for donation and transplantation by making testing available to us, not only available to us locally, but also prioritizing our testing so that those results are turned around to us generally in less than 18 hours. There's already been a discussion about the various types of specimens. I think the only comment I would add there is that we have the hospital staff, the healthcare team in the hospital, obtain the specimens for us, and then we do the testing outside of the normal internal testing protocol of each of our donor hospitals, and so that helps sort of protect against concerns that otherwise the hospital might have when if they're doing testing on an inpatient, they would have to put that patient in isolation and that sort of thing. So we found that to be a useful way to get around that particular challenge. As far as the things that I think we would like to share with the rest of the OPOs based on our experience with more of an early surge of this virus here in the Northwest is that you can and should expect there will be eventually shortages of PPE. We've already heard some comments along those lines. We're seeing some extreme shortages of PPE in our hospitals now. So we've actually created kits for our staff to take on site with them. And we've sent those to all of our coordinators and all of our staff who are going to be spending time in the hospital, so they can bring in their own masks, their own gloves, their own gowns as needed. And so that's something that is, I think would make sense for others to begin to prepare for. We're also seeing an increase in restrictions of access to our hospitals. So we try very much to limit the number of staff who are actually entering the hospital at any point in time. And we're using remote communication technology like telephone or Skype or FaceTime or other technologies to the extent that we can to minimize the number of staff from the OPO who are present in the hospital. That being said, obviously, when and if we need to have people at the bedside or in the operating room, we're not in any way minimizing that presence, but otherwise, we're just trying to do the right thing. The third thing I think we can anticipate is travel restrictions. I know I read recently in the New York City area now, the staff are actually being stopped on the roads and that sort of thing with inquiries as to where they're traveling to. And I think providing our staff with some documentation of the nature of the life-saving work they're involved with is prudent and will be helpful going forward as more and more of us are encountering these types of restrictions. The other restrictions that we're seeing, especially up in this part of the country now, are restrictions placed by state governments, alerts from the governor's offices, and mandates regarding what medical procedures should be suspended. So what we're doing is reaching out directly to our state governments and state departments of health to get their support in writing for our staff. CMS has categorized transplant surgery as a Tier 3B procedure, which is a do not postpone category, and we're making sure our staff are prepared with that documentation so that when hospitals begin to question whether or not donation is a critical, essential medical procedure, we're able to support ourselves and move things along. Another thing to bear in mind is that hospitals are restricting who can enter, and so we are trying to the greatest extent possible provide local recovery staff for organs that are going to be sent out of our DSA. And I know this is happening elsewhere around the country more and more. But I think as we continue forward in this situation, we're going to need to rely more heavily on having our local recovery teams recover organs and send them to distant centers. And lastly, there's increasing pressure from our hospitals to move our cases along more rapidly. There's obviously growing competition for ventilators and for ICU beds. And so I think we should be anticipating and preparing for being able to move the donation process along as quickly as possible, while balancing the need to do the appropriate testing and the appropriate evaluation and place the maximum number of organs. So again, that's all I have for now. Thank you for the opportunity.
I won't add much more, but can you hear me?
Yes, we can, Kelly.
Okay, great. Those of us with donor care centers are working rapidly with our hospitals to transfer those patients once authorization occurs to the donor care centers. We are seeing a few more issues with DCD because of the vent shortages, OR shutdowns, and the time constraints that Kevin addressed as well. And I think that really just kind of minimizing our staff exposure, using telemedicine when when able, huddling with the staff that way, trying to just decrease the burden on the hospitals is what the OPOs are working towards. So that's all I have to add to Kevin.
Hello, good afternoon, everybody. Thank you for putting this together, and I will be happy to present the protocol we are trying to implement in Bologna to address the issue of managing the candidates during these COVID outbreaks. So please, the next slide. So as also has been anticipated earlier, to start thinking about how to manage a transplant program, and in particular heart transplant program and lung transplant program in your hospital, you should start to take yourself some questions. So the first is, if you have a COVID-free path in the hospital, if you have screening facilities for the donor. We have heard that in US OPOs are able to, in multiple cases, to have screening facilities for the donor. In Italy, we started to screen all the donors by the end of February with PCR in the BAL, and now also with CT scan. Also, it's important to consider how prevalent is the SARS COVID in the recipient area, because if the recipient is coming from a very high prevalent area or not, how sick is the recipient, because we have to weigh how is really life-saving that potential donor for that potential recipient, and if we have the possibility to screen the recipient, because we need to consider how to rule out the possibility of having COVID in our recipient. Also take into consideration that if we live in a high prevalent area of COVID, in just for instance to make you the case, in my area currently we have a prevalence of 1 case every 500 people. 1 confirmed case is every 500 people, considering that the PCR is done only in symptomatic patients. So we may have 1 case, 1 person out of 100 patient, 100 subject that can be affected in our area currently. So it's quite highly prevalent. So it's important to screen the patients, knowing that we cannot rule out completely that he is COVID-free. So the next one, please. So we need to balance the risk of transplanting a COVID recipient and the risk of a COVID transmission in the post-operative period with the risk of the patient to risk the transplant. So this is how, and this is often is a gamble. So how COVID-free is my ICU? How can I ensure to my recipient to avoid the possibility to get the infection in the early post-transplant phase? Another alternative is, do we really have alternative? For example, if we have COVID-free path, considering using an LVAD for heart transplant recipient may be an option, only because we don't have immunosuppression. But again, we don't have data on LVAD patients infected by COVID. And on the other hand, another important issue is to consider to accept only good organs to minimize the risk of early graft dysfunction and long ICU stay. We have been discussing a lot in the community, in the heart transplant community in particular, the acceptance of marginal organs. In this case, during a COVID outbreak with the ICU shortage of staff, I think it's not a good idea to accept a marginal organ with an anticipated long ICU stay. So we should focus, if we really want to go on with the transplant program, on very good organs. Next one. This is my last slide, and very briefly, you can screenshot it. Very briefly, is the protocol we have for the screening of our potential recipient for heart or lung transplantation. Basically, if we have the recipient that is already in hospital and is on high urgency, we periodically screen the patient with a CT scan and with swab. If both are negative, he's on the waiting list. If one of the two is not negative, we withhold the patients from the waiting list. It can be more complicated if we consider a patient arriving from home. So first of all, we have to perform a phone triage of the patient to screen and to write a note of the screening. It's important to have a document of the screening to check for fever if the patients had or had not any upper respiratory symptoms in the preceding 2 weeks. And if the patients had, we would not proceed with transplant, re-evaluate the patient. If he declared he didn't have, we accept the patient with face mask entering the hospital. We again rescreen for fever and upper tract infection upon admittance. If everything is clear, we perform a CT scan to look for interstitial pneumonia. We decided to go for CT scan screening because the turnaround time for a swab is still too long in our hospital. We are now taking fast PCR screening, but this fast PCR screening, they have a faster turnaround time, but they may be less sensitive in non-symptomatic patients. So our idea and our recommendation would be to do the CT scan anyway, and then if you have a rapid PCR technique, you can use the rapid PCR technique, and then to proceed for transplant. Thank you very much for your attention.
Great, thank you to the presenters. I actually have a couple of questions because this is we're really in the meat of what, the information that we've been getting from our state and local and authorities and our hospitals and all. This is really, that's been less specific. This is more specific to transplant. So first, let me pose a question to Mike. What is going on with the risk of transmission through blood transfusions, or how's the screening for blood donors, and what's the blood availability impact of the coronavirus?
So what I would say is the biggest impact is likely not so much the impact of donor-derived coronavirus through blood, but absolute availability of blood. I know in our area we're in critical shortage of platelets, for example, because people are just not going to donate blood and blood products. And so I think that this is something that all transplant centers need to probably have open dialogue with their blood banks to just assess for ongoing availability. In terms of relative risk, I think as Ajit pointed out, we don't have a lot of data on risk of transmission. Blood screening and deferral is very different from organ transplantation in that blood and products collected for blood oftentimes retained for a short period of time, 24 hours or such, to make sure that the patient is without symptoms while other tests are ongoing. For example, we had one instance where a patient donated blood and the following day became ill and tested positive for coronavirus. So that blood product was quarantined and disposed of. So it's a bit of a different level of risk from blood donation. And we really don't have good data on frequency of transmission of these viruses. I think that respiratory viruses oftentimes don't have significant viremia for seasonal viruses, so the risk is very low. The frequency of viremia or RNAemia in these patients when they're severely ill is relatively infrequent. We have very little data on patients that have mild or asymptomatic disease to really inform that thought.
Thank you. Let me ask a question to Ajit. So in New York, we're beginning of the surge. And at our center, it looks like there may be a couple of patients who were inpatients and on the transplant service and then got exposed nosocomially and now have tested positive. What are your recommendations in terms of best practices to avoid nosocomial infections?
Lloyd, it looks like Ajit might be self-muted right now. Ajit, can you hear us?
Hear you. Yes, hopefully I'm unmuted now.
You are correct.
You raised a good question, Dr. Ratner, and I think Dr. Michaels brought up some of the strategies that hospitals have used, from adhering to recommended CDC guidance about infection prevention. Our hospital has gone to a cohort strategy, at least for some patients, where there's a separate ward with patients who have tested positive for COVID. It is concerning that you're describing what sounds like nosocomial transmission. We have not, to our knowledge, have had patients acquire COVID while in the hospital. And I'm somewhat encouraged by the Singapore and Taiwan experience, at least initially, that with very rigorous infection prevention measures, that they were able to control at least transmission within the nosocomial setting. The community setting is completely different. So our general approach is, in any patient, as described by Dr. Portena, that is suspected of possibly being symptomatic, who is getting ready to go to transplant, they would be screened. And anyone who has either laboratory or other clinical suspicion for COVID would not be able to undergo transplant unless that's adequately excluded, both by clinical symptoms, epi risks, laboratory testing, CT scan.
Great, thank you. And in the interest of time, let me just pose one last question to Kevin. When the standard questions are asked of the donors, is there a standard way that it's reported in DonorNet? Because at 3 in the morning, I haven't been able to find that so easily.
Yeah, I know that we are recording it in our OPO EMR, and I think that my recommendation would be that I'm sure that every OPO is asking those specific questions. My recommendation would be that if you're entertaining an offer, is that you contact the OPO if you are unable to find the answers to those questions, because they will have those answers for you.
My recommendation would be to UNOS to make standard fields for those questions, just like you have for serologies. I think it would be very useful for those of us who are accepting the organ offers.
So thanks, Dipali, and this is Meryl Johnson, and actually we're going to go on now to some kind of less specific issues related to transplant, but how all of this actually interacts with what else is going on in our hospitals, at least for the first section of that. And I'll again tell about the speakers that'll go in this section. We'll start out with Atul Humar, who's the Director of Transplant ID at the University Health Network in Toronto, who will kind of give us some information about how their center is dealing with this currently, and also has some previous experience during the SARS epidemic. I guess Luciano is listed again, I think primarily to mention a link to the JAMA video, which I think I listened to and people should find very helpful. Interview with an editor of JAMA with a colleague in Italy. Stacy Lorette, who is the chief at the Children's Hospital of Wisconsin down the road from me, will talk about managing patient and family concerns as well as medication supplies. And then finally, Lou Tepperman, who is in the thick of things in New York, will talk about how we can actually interact with and take care of our patients, perhaps in a way without seeing them. So without further ado, I'll pass it to Dr. Humar, and go ahead.
Thank you, Meryl, and thank you for the opportunity. Can you hear me?
Yes, we can.
Okay, great. So I'm going to talk about management of the transplant program in the setting of a pandemic. So next slide. So a lot of the considerations we've talked specifically about so far have been around transplant patients and how to navigate donor and recipient management. But a lot of the planning, I think, will be driven by factors external to the transplant program. So in the context of a pandemic, heavy resource utilization, use of ICU beds, ventilators, and ward beds, with most estimates being about 5 ward patients admitted for every ICU patient, means really scaling back transplant activity is inevitable. And also for donors with limited ICU capacity, workup and identification of donors becomes more difficult as well. The other issue is high rates of healthcare worker absenteeism is a big problem. And then the final thing, which we've already talked about, I think, is immunosuppressing otherwise stable patients during a pandemic. So at our own institution, we've developed a phased approach to transplant volume reductions. And I think this is necessary to try to conserve resources, but also to minimize waitlist impact for our patients. Next slide. So this is a table, and this is just published today online actually as well. And it goes through different phases of reductions that transplant programs could consider, all the way from a 25% reduction to a 50% reduction to all the way to 100% reduction. So in a 25% reduction phase, I think this is when activity is just starting in your jurisdiction and you're doing the planning and you're expecting the wave of patients to come. And there you could think about, for kidney, for example, no live donor activity, but continued deceased donor activity. For liver transplant, no living donor activity for stable recipients, but allow it for more advanced recipients, and continued deceased donor activity. Continue heart and lung activity, but pause on some of the pancreas transplant alone and pancreas after kidney activity. Then in the next phase is a 50% reduction, which I think most places in the US and many places in Canada are at that stage, and certainly many places in Europe, I feel, are probably beyond that stage. This is where you might consider transplant only for semi-urgent or urgent cases, patients who really need the service. And so in that situation, you would pause kidney transplant activity, both deceased donor and living donor activity, except with the potential option of highly sensitized patients who are unlikely to get another offer. You may restrict liver transplant activity to only recipients who have MELDs above a certain category, and that's each jurisdiction has to decide that MELD cutoff. And similarly for heart, you may restrict activity to intermediate status or higher patients. For lung activity, you could allow all patients in that setting still to go forward, but defer for very stable patients. And for kidney pancreas activity, you would generally pause except for high PRA as above. So next slide. Then as you get to a more severe situation where you're seeing a lot of ICU capacity being used up due to COVID, you would go into a 75% reduction mode. And here, really, you would only be doing what are considered the very high need transplants. So liver transplant, kidney activity would be paused for the most part. Liver transplant would be for very high MELD or fulminant hepatic failure. Heart transplant would be high status only, and the status classification differs by country and jurisdiction. And lung transplant would be reserved for rapidly deteriorating patients. And then the final category is, of course, 100% reduction in transplant activity. And there are places that unfortunately are in this situation. And here, there's really no ICU capacity available. There's severe shortages of health personnel, severe shortage of ventilators. And this unfortunately will likely lead to a halt of all living and deceased donor transplant activity. And then I think there should be similar phased reductions occurring in ambulatory activity, the 25%, 50%, 75%, with deferral of non-essential visits and a really aggressive shift to virtual platforms for care. And I think we're going to hear a little bit more about that later. So I will stop there, and thank you very much.
Thank you for the opportunity to highlight essential components of patient and family management. We all know and are certainly experiencing unprecedented demands on our time to care for patients and families. Next slide, please. And while the first thought that comes to mind is clinical care and how we're managing our patients in the hospital, it's equally important to consider how we're supporting patients and families while they're managing their transplant in the home environment. Specifically, the volume of calls that are coming through with questions and concerns to our transplant team is enormous. So knowledge of reliable transplant-specific resources is critical to disseminate accurate information to patients and families. UNOS is one such valuable resource, and you can see a picture of the UNOS webpage that has COVID-19 highlighted. And UNOS has latest updates that are highlighted in yellow and updated frequently, and they also have links to some of the major Transplant Society websites that you can see on the right-hand side under Quick Links. And when you click on these major society websites, they include American Journal of Transplantation, AST, AOPO. It goes directly to their COVID-19 section within their website, so it's easy to access this information. There are also links to Centers for Disease Control and Prevention. Specifically, there are multiple sections that you as a transplant team member can go to and reference that include what you need to know, how you can share with your transplant families how to prepare their own family, and then frequently asked questions sections for healthcare professionals. We know also that access to medications is essential for our patients and their overall health, and we want to consider providing options for medications specifically that patients may or may not already be utilizing. 90-day medication supply might be one strategy that you could implement as a transplant program. If you're currently utilizing 30-day supply, you can increase that, and also potentially medication delivery service if that happens to be available based on their pharmacy. Both of these options are addressing the possible inability for transplant patients to get to the pharmacy to pick up their medications. Also, as a team, we want to be as efficient as possible. With all of the education that we are providing to our inpatients and in telehealth ambulatory visits, as well as over the phone, it's important to be able to document our conversations thoroughly but efficiently. And one way to do that is to create a shortcut within your electronic medical record for the education that you provide. These shortcuts can be used for providers, nurses, and coordinators for them to document their time with patients and families. You can also consider strategies to communicate with families without communicating with them in person or over the telephone. And one such strategy is to provide letters or also documents through your electronic health record. There are two types of letters that I want to highlight here. There's specifically general letters providing information and education about COVID-19 for patients and their families, and then also letters for work, specifically for patients and or their caregivers to be excused from their work or be afforded the opportunity to work from home. There are templates that are available at NATCO, which is the Organization for Transplant Professionals, and you can see the link here that you can use. And what these letters do is really provide a framework. You can edit these at whatever to best suit your program. Additionally, there are two other organizations that I want to point to your attention. The American Nurses Association. There is a screenshot of one of the documents available through their organization on the upper right-hand side. They provide colorful handouts that can be provided as an adjunct to the letter that you send in the mail, or also can be sent via electronic medical record, the electronic health system. And some of the options that they have available to you are handouts titled What You Need to Know, What to Do If You're Sick, Guidelines to Prevent the Spread Within Your Home, and What are Symptoms of the Coronavirus Disease. Furthermore, the World Health Organization is another important resource to be familiar with. This has media resources that include press briefings, as well as videos specifically geared to the public on how to protect yourself during the COVID-19 outbreak. There's also these Mythbusters section, and you can see one of the pictures on the lower right-hand side. This one is specifically addressing the question, are antibiotics effective in preventing the new coronavirus? These are free and available for download and can be added into your letter that you provide to patients and families. These are all resources that can be used in written communication or can also be used to inform your conversations with families to help them feel informed during this challenging time. Thank you.
Hi, I'm Lou Teverman in New York, and as Lloyd had told you, it is true. There truly is. We haven't hit a peak yet. There are over 20,000 individuals that have tested positive. We have 200 individuals in our hospitals right now, in our main two hospitals, with 60 individuals in our ICU, and we are repurposing our employees. If you can give me the next slide. I'm going to speak to you a little bit about telemedicine, which was turned into telehealth. Initially, telemedicine just referred to the physician, and telehealth refers to all the healthcare providers and all the support staff that we can use in education and of course, remote monitoring of our patients. Right now, for our outpatient clinics in New York, 90% of the visits have been, they're no longer an inpatient and in-person visit, and we're looking to telehealth to help us out. Telehealth initially was for care in the rural setting, and then it was supposed to be used by the military for forward deployment and difficult to reach settings. And now, of course, we're using it for COVID. And it has been underutilized in our country and for disasters. It can manage the surge of patients and handle closure of outpatient offices, which is now happening throughout New York. It allows clinical experts to respond without being there. This will be a test of our system. So telehealth, for our Italians, I'm sorry to say this, it's all about who has control. It's HIPAA. HIPAA, and I'll tell you the new caveats to this. HIPAA stands for Health Insurance Portability and Accountability Act. And there were real compliance changes in 2003, and that protected health information, and they were linked to payment. And this is why telehealth has not really surged until March 6th, when our government said they lifted geographic restrictions, and now private carriers and Medicaid, we were allowed to bill for point-to-point physician care. And then the secretary expanded Medicare coverage for telehealth visits in March 17th. And there's a link to this in the documents associated with this webinar that you can read for FAQs. And so they waived potential HIPAA penalties for good faith efforts for telehealth, and they looked at cost sharing for beneficiaries and reduced and waived them. And so essentially this is a get out of jail card, get out of jail for free. If you make a good faith effort and you record your events with telehealth, no one's going to come after you. So we have two main types that you can use. Virtual private network, that is trying to make a tunnel. So imagine that you're going through a mountainside tunnel and no one can see inside you. That is one very protected area, and that stands for a virtual private network. And instead of sharing the fiber traffic, it's totally protected. And you can notice these to know if you're on a protected network when it starts off with HTTPS, and that's a secure address. The other way is what we're used to now is end-to-end encryption. So, your phone can work that way, and WhatsApp will work that way. So on one side it's encrypted, and the other side, the receiving end, it is unencrypted or decoded. So you can set up telehealth to one of your patients with one of the programs that you can use, and everyone's using different ones. It doesn't make a difference as long as they're protected. And send an SMS text, have your patient then press that, download the program, download the software, then make an appointment, connect to them, and then you can record this in the medical record and you're home free. Next slide, please. So what are we doing? There are many ways to do this. Just to let you know, we are employing Amwell, which is American Well, which uses the cloud for one of our concepts. And we're using the Surge with these carts that you can see to treat COVID-19 patients. You don't want to necessarily get in all the rooms. The one on the right is an eICU. Our transplant ICU, which is the newest ICU in the Northwell system, is eICU. So there are cameras and monitors and microphones throughout the rooms, and the patients can see you, you can see them. That unit has been turned into a COVID unit. It's 18 beds. It's all full. It's an ICUs and ventilator. So we're now we don't allow family visitors to the hospital at present. And so these patients can communicate to their loved ones through this. They can see them. And then we're also having to communicate end-of-life issues when family members are not allowed in the hospital. So telemedicine will help us succeed and will also help us in some of our darkest hours. I do believe that this is going to be a marathon, not a sprint. And I think this is an opportunity to use telehealth. Thank you very much.
So thank you, Lloyd. I think that there's a lot of information that's coming through here. And I think that, you know, unfortunately, in the interest of time, I've been said that I have one question to really ask people. And I guess I will go back and really ask Dr. Humar, you know, you actually had those 50, 25, 50, 75%, 100%. You know, where are you in Toronto now? And, you know, we can't predict the future, but, you know, how can we prepare best in our own centers to deal with the issues that are coming forward?
So that's a good question. In Toronto, we're approximately at 50% or a little bit higher than that pause in activity. And the current state in Toronto is that there's a fair amount of community transmission going on. We're starting to see patients admitted and some in our ICUs. So we've paused all kidney activity with the exception of high PRA. We're continuing liver, both deceased and living donor liver activity, but prioritizing it to the higher MELD patients. For heart, we're doing higher status patients. Our lung program's a little bit unique in that, you know, we do 200 lung transplants a year, and our ICU tends to be full of lung transplant patients. So we put a more severe pause on our lung program just to try to free up some ICU capacity in anticipation of a big surge. So we're only doing very rapidly deteriorating lung patients.
Okay, thank you. And I guess the other thing I will say, because we don't have time to really go into it, but I will try to make sure that everybody that's on the call and in some of the materials has the link to the JAMA video, which I think is also very helpful in this regard. With that, and in fact, it may, I don't know, they'll have to update me and see if that's actually on the resources that is actually on the link there, and the staff can probably provide that information. And with that, we'll go on to next steps. Stuart.
Try again, Stuart.
Go on to Tim,
Yeah, okay, so can I have the first slide? This is actually a really interesting thing. What do we need to know? The answer is everything. There are two major domains that I think we need information on. And right now, certainly in the systems which are being overwhelmed, which is like what Lou was saying, we just need to know what we need to gather, and we can accumulate it after the fact, but we need to gather the basics. And the basics are twofold. One is the course of the disease, and the other is transplant-specific issues that we need to go. You saw a little bit of things earlier in terms of the Washington experience regarding what kind of transplant patients were there, but we clearly need to know the differences in outcomes by type of transplant recipient coming forward, lung versus probably everybody else, but we don't know. The time from transplant, the duration and degree of viral shedding or viremia, and in particular, because we've had so much experience with RNA viruses in the past, does immunosuppression prolong either viral amounts and potential transmission of disease, or shedding
and clearance afterwards. Preliminary stuff looks like it doesn't matter, but I think if we can get any type of information, it would be remarkably important. The other thing is the impact of immunosuppression changes on the course. Are we going to see any rebound infections, induction of antibody-mediated immunity or rejection? What's actually going to happen? And the very important thing is going to be, for those of us who continue to transplant, will the COVID-19 acquisition early after induction immunosuppression alter the clinical infection? There just haven't been all that many done. So as we move forward, the transplant programs, we all need to keep track of this and what type of immunosuppression we use, whether we use depletional drugs or non-depletion is going to be pretty key. The organ availability in donors has been talked about a lot. We do need to make sure that we keep track of what happens to our live donors, that in fact they are okay. We need to know whether there's hospital-acquired infections or community-acquired infections in this population that's potentially induced by surgical procedures, and certainly deceased donor organs. We just need to know whether there's a risk with the donor and the demographics. The treatment is going to be whatever comes out with the treatments, whether it's the antivirals, the anti-IL-6, the anti-immunomodulators, the anti-malarials, they're going to be done under some sort of IRB. The transplant-specific components will not be part of the standard subset analysis, and we need to know who we have going forward, which goes on it. And with the rise of the use of vaccines, which is something we obviously need, we're going to have an understanding of what the impact of our immunosuppressive regimens are on antibody generation and efficacy, as well as titers. There are just a ton of transplant-specific things that we are going to need to know, that we need to, as the practitioners on the transplant side, make sure we collect this data so that it can be put together into some sort of meaningful accumulation at the end that we can make sense of. The next piece, next slide. The other domain that we really need to know is sort of what's been going on with the transplant-specific capacity to provide specialized transplant care. Will it break down, and when does it break down? As Lou is talking about, the transplant-specific providers will be repurposed to other places, and what's going to be the consequence on our patients and our programs. And as Atul was mentioning, there's a varying phase of performance or non-performance in terms of what goes on after the fact gets done. Understanding what we've done in terms of rate-limiting issues, either self-inflicted or resource external inflicted, we're going to need to have some sort of analysis and understanding. The one which I'm actually quite concerned about is the impact on transplant healthcare workers or professionals, the number that are too sick to care for other people. I think the guys in Italy have seen this happen. There's a fair bit of literature on that, and we're a pretty small population of people. And if we go out, and how many of us do go out for infection or isolation, how's that going to impact existing transplant recipients or the ability to provide care? I think we need to understand a lot of this. We need to keep track of it inside of our own systems, either through administration or through our coordinators, just to keep an issue, because when it's all said and done, we're going to need to understand the impact of what a major system breakdown does to our patients. And I think that's it for right now. Thank you.
Thank you, Tim. Can you guys hear me now?
Yes, we can, Stuart. Thank you so much.
Terrific. Our next speaker is going to be Ashley Morgan, speaking on behalf of AJT. Dr. Kirk is apparently not available, unfortunately. Go ahead, Ashley.
Hi, my name is Ashley Morgan, and I'm the managing editor at AJT. We wanted to let you know what we are doing to support the community during this pandemic. We are accelerating review for all COVID-19 manuscripts. You can see our manuscript types, word limits, reference limits here for submissions. Further instructions are at amjtransplant.com/instructions. Next slide, please. And we are reviewing all formats. All articles are going to be free to access for everyone in the interest of facilitating patient care and advancing science and ensuring that accurate knowledge and experience is available to all during this current time of crisis. We are expediting papers, as I said before, and they will be free access. And they are all collected in one place for easy access at amjtransplant.com/COVID-19. That is updated usually daily, depending on what we have published and what we have ready for readers. And that's it for me.
Thanks very much, Ashley. And I'll just comment that what you're doing at AJT is being mirrored by other transplant-related journals. I do know that the Journal of Heart and Lung Transplant is also working to get COVID-related manuscripts reviewed quickly, and the ones that are accepted posted quickly. There is a separate website there as well. I don't know if there's other specifics, but perhaps we can gather that information from other journals as well. If we have time for one other question, I guess I would ask Tim, recognizing that the data is changing so quickly, how do we understand as a community the data that's coming out here in terms of small uncontrolled studies, and how do we leverage the bits and pieces coming from everywhere to gather information that turns out meaningfully?
Yeah, I think that's a really difficult thing to address, Stuart, because we all have our own individual perspectives. We just did a liver transplant society meeting with this morning with lots of different folks from around the world, and everybody has small numbers which are really statistically insignificant by themselves, but the necessity of collating this data is real. Now, whether we can do it through a national system, such as through UNOS, and to set up formal data fields moving forward with certain boxes and ranges of elements that we want to look at, I'm not sure what's available. I don't think we've ever confronted this type of thing before. The societies may be able to help arrange it either through the AST or the ASTS, and we are just in new turf. But unless we at least accumulate important issues regarding what we see and the sequential nature of what we do in transplant, which we all do. I mean, everybody's participated in some form of a trial somewhere, I would think, in which we look at immunosuppression and clinical outcomes and all the different infectious related issues. We can, without prospectively doing it now, we can all sort of keep track of some of that data, and eventually at the end come up with something which may not be clean, but will at least help guide us towards the future.
Thanks, Tim. I guess I'll just make two comments. First of all, I think the group in Seattle is trying to do some of that collection through a local database, and I would encourage all of you to look at that. The second is both AST and ISHLT, and I'm sure there are others, have very active message boards where people are sharing their experience and answering and asking each other questions. I think those boards could also be used for collecting some of the anecdotal experience, and we at ISHLT are thinking about how to do that. I suspect that Emily and her group at AST are doing that as well. And in the short run, using those places may be as quick and easy a way of gathering information as we can get.
Thank you, Stuart. This is Emily Blumberg again. I'd like to also mention that I know there's a European group, the Increment group, that is also collecting data. This webinar has been our first attempt to really have a multi-society outreach to try to help us all deal with what is an extraordinary circumstance. We're very interested in learning what you all thought of this. We want to be here as an international collaborative to help, whether that means collaborating on research studies so that we don't have these pockets of research that are sort of disconnected but can somehow be integrated, or whether it's to create additional webinars. We're thinking of actually doing some modules that might be able to be accessed in shorter bites that might be accurate and helpful to people when they need them, especially because we feel that this is such a rapidly changing landscape that we want to make sure that we are current for everybody. As I mentioned at the beginning of this, we will have this webinar available through all society websites. And if there's a society you're a member of that you think would be interested in that, please let the organizers of this know. And you can just respond to your specific invitation, or you can email me via AST as well. Additionally, we will have all of these resources available as a handout, and it will be posted after the recording of this call is completed with links to all the web pages. And we are working very actively to make sure all of our resources and those of other societies are up to date. And so the best thing to do is to keep using those links, which will keep you updated. You guys have all been very patient, and I notice that many people are still here. In order for us to best serve you moving forward, I'm going to ask your patience for one more minute to just answer two polls, the two questions on a poll. This will literally take less than a minute. And so we're just going to ask you two questions, whether you found this to be helpful. And we'll give you a minute to just vote there. And then our second question for you is coming, I think.
Yep, we just have to
Whether or
switch
not
it.
you would be interested in participating or viewing future updates to this webinar. If you have other things that you think would be very useful for us to be working on as a collaborative group of societies, please email the individuals in your own society who are involved in this, and that will be on the resource page too, so that we can know how best to serve you moving forward. We are definitely interested in trying our best to really provide people with things that will allow us to all serve our patients to the best of our abilities moving forward, benefiting from each other's experience and knowledge. I'd like to thank all of the presenters and our moderators and the organizing committee for what's been a lot of work in a very short period of time. Please continue to take care of yourselves, be well, and many thanks for your attention, and also to the organizers, the staff people, Brian Valeria and Erica Ng, especially for helping coordinate this webinar. So thanks very much.